finding your way back from lunch and a little carb blast there to come and enjoy our session. We'll try and keep it lively. We'll try and keep it active. There may be calisthenics if you got to the dessert table, so stay tuned. But what I'd like to do to begin with, I will just mention that my district is House District 80, and it's a very unique district in Florida. I represent the eastern portion of Collier County and all of Hendry County, and in that regard, I have some very, very unique healthcare challenges in my district. Hendry County has one hospital, clear on the eastern side of the county. That's the only hospital. It's a critical access hospital. It has 25 beds, and they don't deliver babies there. And they have a volunteer fire department. And so EMS is a little challenging as well. So the things that we normally take for granted in a lot of our major urbanized areas are not necessarily what my community sees. And I think that helps me frame the discussion in Tallahassee when we talk about healthcare in general, just from the standpoint of making sure that we recognize all of Florida and that there is not just one Florida to talk about. It's not just the urbanized areas, there's also the rural areas. Now, the one unifying conversation that can be had between both is that we all have employers in our districts. And each one of those employers is wrangling with how to provide adequate health care to their employees and also make sure that they have a healthy, stable workforce. Because after all, they're in business to be profitable and to make sure that they're serving the needs of their customers and expanding their businesses. So today's panel, I'm very excited to hear three different approaches that had that unifying theme that you'll get to hear about. So I'm going to introduce each one of them. Each one is going to take 15, 20 seconds and tell them who they are and where they're from. And then we'll start back around and we'll hear each one of them give a little bit of detail about what's unique and what they're doing at their corporations to bring about health wellness, to bring about innovative ideas in healthcare, and to ultimately look for solutions that can be replicatable in part or in totality by other businesses around the state. There is not just one mousetrap to this issue. It takes all of us to come up with solutions, and that's what you've been hearing today from all the other wonderful panelists and from all the other wonderful presenters. So first off, I'd like to introduce Dr. Richard Luceri, who is with JM Family Enterprises. Dr. Luceri.
Thank you very much, Representative, and thank you for having me on this panel. It's certainly a privilege to be here among all of you who are, have an acute interest in healthcare issues. I am a physician and a cardiologist for most of my career, an invasive cardiologist, and today I'm very happy and privileged to represent JM Family Enterprises. We're a company, a diversified company based in Deerfield Beach, Florida, founded by a very visionary car guy, Jim Moran, who was a very well-known Ford dealer in Chicago and who moved to Florida in the 1950s when he thought he had a debilitating illness. It turned out that he didn't, and he was back in with both feet into the automobile sector. And at that time, Toyota was trying to implant itself in the U.S., and he was able to negotiate an exclusive distribution deal with Toyota to distribute all Toyota vehicles in the 5 southeastern states, the Carolinas, Georgia, Alabama, and Florida. And so we are the largest Toyota distributorship in the world, responsible for approximately 19% of all Toyotas, 19-20% of all Toyotas sold in the U.S. The company expanded to the warranty, automobile warranties, finance, et cetera, all things surrounding the auto industry. Well, he didn't stop there. He was a very, very caring person, and he felt that associates in the company were like family to him, and he wanted them taken care of. So in 1989, Jim Moran hired his own private internist to take care of everyone else in the company at headquarters. That original clinic, which is now 25 years old, morphed into a total of 9 clinics, company-owned clinics staffed by physicians and nurses. Our northernmost facilities in St. Louis, Missouri, where we have a call center. We're down in Mobile, Alabama, a couple in Georgia, Alpharetta and Commerce, 3 in Jacksonville, where we take the cars and soup them up, essentially, from the port and from railheads, and, of course, down in South Florida headquarters. We also own one dealership ourselves, and that is JM Lexus, which happens to be the largest dealership for Lexus vehicles in the world. We have a small clinic there. So we provide free on-site medical services using physicians and nurses. So by way of intro, that's what we do. Thank you very much.
Well done, Doctor. That was a heck of an intro, by golly. Next up, we have Mr. Ashley Bacow, who is with Preventure, who provides the services here for the lovely facility we're in for all of the Rosen properties. And so, Mr. Bacow.
Good afternoon. Thanks for having me, and I guess most importantly, thanks for having your conference at Mr. Rosen's hotel. We really appreciate it. Proventure is an insurance agency and risk management consulting company that's been very actively involved in helping Mr. Rosen launch he calls it his Rosen Care model, and I'll get into the specifics of that in just a few minutes. But in short, it's a on-site clinic model that the costs are much, much less than the average, and the benefits are much, much more than the average.
Okay, very good. And last, but certainly not least, is Dr. Tin Tran from Baptist Health South Florida. Doctor, welcome.
Well, thank you, Matt. Again, thank you so much for having us here today, and it's a pleasure to be on the panel. Baptist Health South Florida, health is the cornerstone of and part of our name. So focus on health rather than sick care is part of our DNA. And really focus on that component about wellness prevention for not only our employees, but our community. It's really been the work of our men and women, our leadership. And I'm going to touch on several things today. One is about leadership. Second is around accountability and ownership of the community we serve, and also innovation, which is the last topic. I'm Tin Tran. I'm the Chief Medical and Quality Officer for Baptist Health South Florida. Beside quality, safety, operations, research, education, wellness prevention, new modern innovation is really part of my work today, and it's really underscored the importance of wellness prevention as we move forward in terms of the new era of healthcare. So thank you. It's a pleasure being here.
Thank you very much, Doctor. Before we get to each of your individual presentations, I have a question. Each of you, very quickly, how many employees are in your organization that you are managing the healthcare for? Mr. Bacow?
4,000.
4,000. Dr. Luceri?
We have 4,000, and with the families, we cover approximately 10,000 lives.
For Baptist Health South Florida, we have approximately 15,000 and growing. And under our self-insured health plan, we cover north of 38,000 lives.
Excellent. So you have kind of a mix here before you from 4,000 on up, but effectively, these three folks manage the healthcare for roughly the city of the size of Naples. So it's important. When you think about our employers in the state, they range in size, but the work that they do and the magnitude and the impact they have on things is significant. So why don't we start to my right here, Mr. Bacow, why don't you lead us off and tell us all about the good things going on here with Rosen Care?
Sure, be glad to. I mentioned 4,000 employees. We have about 5,200 covered lives on the plan, including dependents. In 1991, Mr. Rosen decided that he had enough of the continuing escalation of healthcare premiums, and he wanted to take control of his own destiny. And so he became self-insured. We were fully insured. Became self-insured and opened his own primary care facility. We thought about hiring a third party, and then I think that moment lingered for 2 or 3 seconds, and then he decided he's going to do it himself. and he converted a accounting office in his hotel, which is about 2 miles from here. He converted the accounting office into an on-site clinic, and we had a part-time doc at that time. Our cost at that time were a few $1 million, not maybe $2 or $3 million. We have since grown into I think we started with 3 folks at the medical center. We've since grown into over 40 staff members. We have 8 providers. Mentioned the 5,200 covered lives. We save about $15 to $20 million a year by having this model. We've had a couple of large insurance carriers come in and study our numbers, and they have told us that if we had this identical demographic in the conventional healthcare setting, that is, either on a self-insured plan or a fully insured plan without the on-site clinic model, that our cost would be 30 to 50% more than our costs now. When you drive by our on-site clinic at 30 miles an hour, it looks like all others. And it's been quite a buzz over the last few years. There are a lot of them out there. But ours, when you really get inside of it and peel the layers of the onion skin back, you'll notice that it's much, much different than the average. Doesn't mean we're smarter than the rest of the folks out there. We started small, and we incrementally made commonsensical changes along the way to match up to the needs and the desires of our employee population, and of our pocketbook as well. Most on-site care facilities, they provide maybe just the occupational care for maybe just the work comp. They may provide the work comp, and if you want to go by there for some sort of episodic situation like the sniffles, or you cut your finger or whatever, most employees use these type facilities under those conditions. Our program is mandatory for all of our employees. If they want health care at Rosen, they must use the Rosen primary care facility for all of their primary care. That's with the exception of pediatrics. 14 years of age or younger, we have a large list of specialists that they can go to, but everybody else, all primary care comes out of that facility. Now, we have a relationship with a local hospital chain where we go directly to the hospital. So we're not going through an insurance company. We go directly to the hospital. When there are rare situations where this particular hospital chain cannot handle our needs, we open up the network to where we need to go. A lot of, I think, health plans, they're very specific. Again, we just go back to common sense. As soon as a situation arises where the expertise is not in this town, we find the best performers in the world, and we go there and get the service done. We have a lot of incentives for our employees, and we're moving more towards the outcome-based incentives in 2015, but we do have several incentive programs for our employees. One program, which is pretty nice, is all of their health care is on the clock. So when they go see the doc, they're on the clock. Our doctors spend much more time with the patient than the average doc does. I don't think the system is set up properly to allow a primary care doc to spend much time with the patient. We immediately saw that flaw in the conventional healthcare program, and we allow our doctors to spend as much time as they want. And the more time that they spend with the patient, they really get to the root cause of what is driving the illness, and we've been quite successful in really getting to the bottom of things quickly, and keeping people out of the hospital. Our our costs, again, are 30 to 50% less than most. Our work comp costs are about 50% less than the average work comp cost. Our costs have stayed relatively flat over the last 5 years, whereas the rest of the nation, you know where you've gone, and it's on this unsustainable track. I think there are some the paradigm out there is changing. We're hearing a lot of neat things that are being done to help folks, such as paying docs based on outcome and that sort of thing. So I think a lot of good things are on the horizon. I think it's going to take quite a while for it to manifest into some great care and savings. But I think we're well on our way. My concern is that most employers, a lot of the changes that are going on now, although a lot of people in this room would cringe when I say this, they're painful, but they're subtle. And the way these increases, this unsustainable increase of healthcare trend is going, I don't think we need to let subtle enter into our vocab. I think if employers do not drastically do something different than they're doing now, forget subtle, drastically doing something different than they're doing now, they're not going to be able to handle the cost of health care, nor is the state of Florida or the country. Thanks.
Thank you very much. Well said. Next up, Dr. Luceri, tell us all the good things going on at JM Family Enterprises.
Well, since I had that fairly long introduction, let me just comment on what Ashley said. You could practically give my description of what we do, because it's very similar. And
I did see him. I saw him cheating off your paper. To be honest with you, I don't know. It's weird.
I didn't bring any paper today, so I'm just winging it. Let me take this discussion to a slightly different level, because in piggybacking on my experience as an invasive cardiologist for most of my career, we have, without a doubt, probably the best overall healthcare system in the world. People come to America for healthcare, and it's the envy of the rest of the world. But I think we have to look at what are they coming for. And they're coming for the most part, and the thing that we're extremely proud of, is the advanced care. The care from specialists, the care from high-tech equipment, the surgery that no one else can do, all the innovation, the technology, and all that. That's what makes America great in healthcare. And I've seen that. I've lived in that space. But there is something wrong with that space, something that I observed myself that became one of the motivators for me to do something else with my career. And that is that the pleasure and the honor I had taking care of each patient who had a terribly sick heart really made me think, if only we could have prevented what I'm taking care of. And a lot of my patients lost their battle from heart disease because they were diagnosed too late. A lot of them with the World War II generation, the greatest generation. And as I said, although I had the personal privilege of taking care of them, I said there has to be a better way. And that better way is where we're not the greatest country in the world, and that is taking care of people on the other end, on the end of prevention, on the end of primary care. The things that are not sexy, the things that don't get the grants for millions and millions of dollars from NIH. But they're the basic foundational pieces of doing our jobs as physician and healthcare people. And so when I took this position 6 years ago, I said to myself, this is great. I can use the other part of my brain that did not struggle to get someone from age 84 to age 84 and a half at a cost of $500,000 of Medicare money. But if I can direct my energy to the 30-year-old who has hidden or pre-diabetes or hypertension that in 5 years will cause problems, or 10 years, then we're really doing something. And I admire my colleagues here who started in that arena. And I think there's a lot to be said about where America doesn't do well. And talking to the representative earlier about his district was very touching. We are one country. And if he faces those problems in the United States of America, that's a problem. That's a problem with basic primary care. So let's take the situation today. Yes, my company recognized that. Our founder was brilliant. He was visionary. He made that investment in time and money. We have all these great things in our company that we're very proud of. And I'm glad to see this discussion really getting legs. And it's about time that we started focusing on disease prevention and wellness and getting to the 30 and 40-year-olds before they really get sick, because that's really where the benefit is. And a lot of other countries actually do that better. One of the problems we have is we don't have enough primary care physicians. So now we're using the word provider when before we used the word physician. And provider could mean a lot of things, all of which are good. Nurses, physician's assistant, nurse practitioners. We have the technology, and I think you said it best about innovation. That's very important. We have the technology to connect all over the place. That was a great talk by Ms. Green from Verizon on what we're capable of doing to get all these pieces together. So I think it's very exciting now that we're seeing forward momentum in this domain. Let me talk about the company a little bit. We try to be forward-thinking, and we try to solve issues. And again, one of our key strong points is by spending time from a primary care focus, whether it's with our nurse coaches or our physicians, spending time with the patient. And it does save money. Fortunately, my CEO doesn't ask me for too many ROIs. In fact, in the 6 years I've been here, I haven't been asked yet to do an ROI, so we're pretty, I hope I'm safe for a couple more years at least. But it's that time spent with the patient, getting to know them, getting to know their families, finding out what their stressors are. Is work making them anxious? Is home life? Is work, the so-called work-life balance, contributing to their lack of well-being, their sense of well-being? So we try to get involved in the lives of our associates. One of the things that's key to the success of our operation is privacy and trust. We build privacy because we want to be totally separate. Even though we're employed by the company, we don't want the patients to think that we are agents of the company and that we report back to the boss about their health care. So we're very, very keen on keeping a wall of privacy between all of our operations and with the various departments such as HR, compensation, et cetera, et cetera. All of our services are on company time as well. So not only physician services, nurse coach services, physical therapy services, we have wellness programs, and all sorts of fitness programs. We have certain specialists that come on site in some of our locations. We like to partner with very prominent hospital groups. So, for example, take Jacksonville, for example. We use Baptist Health System in Jacksonville as our partner, and they provide us with part-time contracted physicians because our clinics there are small, can't support a full-time physician. And we do that in different locations. So we're looking for local community partnership. That's where our folks live, and we want to support them where they live. Another important thing is the incentives that we provide. And make no bones about it, we provide financial incentives, but we know that they will only last a short time to get patient engagement in their own health care. That's vitally important. So we use financial incentives, money, as a hook to get them in, but once they feel that we're taking care of them and that we care about them and their families, we hope to be able to pull back on some of the incentives and get them more engaged on their own in the health care, regardless of whether or not there's a a dollar figure. So, for example, we provide $700 to each adult, spouses, in wellness incentives. And we try to do the ones that have the most impact. So, for example, if they come in for a complete physical exam, including pre-screening labs and EKGs and whatever they need, they will get $300 deposited in their health account for a physical. To go to the gym and work out, they might get $50, and that has a limit on maybe, I think it's $200 this year. So how many sessions they do. And that's predominantly for the real healthy ones who really don't need any medical services. We have to provide something for everybody. But $300 to get a physical, an annual physical where they spend 1 hour with the physician. Physician can get to know them real well in an hour. So those are just examples. We're looking at narrow networks for specialists, where we can select the best people in each location who will be the orthopedic surgeons, who will be the cardiologists, whatever, for our associates. So we really have our own little microcosm of health system, similar to what you guys do, and I'm sure what you do, Tin. And, I think the common ground for all of us is the engagement. We care about those who work with us. We care about them. We want them to stay healthy. We want them to retire healthy and be able to spend their retirement money without, like my former patients, husband and wife, they had to look on their calendar. When I asked them to come back for an appointment, they had about 8 doctor's appointments each month on their calendar. I think there's a better way of doing it. And hopefully in this area of primary care may be the way. So thank you very much for listening.
Thank you very much, Doctor. Dr. Tran, tell us about the good things going on down in South Florida.
Matt. I appreciate it. Well, one of the things that I'm hearing, and of course, I touched on a little bit earlier, is around leadership. Just like Matt, in his leadership in terms of governmental and really focus on resources for the community, my 2 colleagues here related to their own leaders actually driving the vision here. I think that's required, and I think one of the lessons learned is really leadership at each organization will drive some of the execution. And execution, that's where it's really drive some of the rewards and yield the outcomes you want. One example that at Baptist Health, without Brian Keeley, our CEO and president, who's an avid champion for our cause, he actually even authored a book recently for our employees called My Body, an owner manual for Baptist Health employees. And actually, we share with all employees, our board members, our physician, and also new employees coming in. It's really talk about healthy lifestyle and tips, and very easy to understand. He actually walked the walk. I mean, that's the thing, right? If you're going to be a leader, you need to walk that walk. He walked to work. He actually eat healthy. He speak about healthy living. And we also, at our corporate runs, where our employees and family are able to join for a healthy day, he's always there. He got all the CEOs out there and board members to be there and really visible in that component. And really, the cheerleaders continues. But also invest in the infrastructure. We talk about the infrastructure of the availability of access clinic, at on-site clinics, so they don't have to be interrupt from work, go to waiting a primary care appointment for a couple of hours and come back and disrupt their days. Have it there and actually able to access that care. But also provide an opportunity to identify those that actually have chronic disease that seem to be out of control and actually tap into. The investment also going to health fairs. We actually do annual health fairs, volunteer health fairs. Just imagine we have 30 different sites. We have 7 hospitals, multiple shifts. We are actually able to staff our wellness program to accommodate for everyone. 80% of our employees actually participate in that health fairs. Why is it so important? Because that's the entree to the conversation. That's the entree into exactly what are your biometrics doing, from BMI to your smoking status to your blood pressure to your cholesterol and so on. And by the way, we actually incentivize those activities. If your blood pressure, your cholesterol to target, you actually have $50 incentive in your health account to spend if you actually get to goal. And by the way, smoking status, yes, indeed, you actually can declare your smoking status as a non-smoker, but we also validate it through the CEO testers, breathalyzer tests, to make sure that indeed that's the case. And so again, it's metric-driven. Through that data, from the identification of the health plan data, through the employee clinics, and to health fairs, we actually to identify, and we all know, there's about 20% of our employees' database and actually use up to 82% of the healthcare costs and drive that. And focus on that is very important. Let me share with you some of the very tactical things that we're doing around employee chronic disease management. We know that just light touch or telephonic or web-based doesn't work as well. They need to have a high-touch, personalized interaction. So I'm going to share with you a program at Baptist Health that we launched about 4 years ago. It's called My Unlimited Potential. It's really about the ability for an individual, through the commitment, to change their life and their family's life. And the programs invite specific individuals based on their biometrics and their utilization. It's a volunteer program. It's a year-long program, a team-based program. 40 individual cohort that come together, support by a physician, nurse practitioner, a physical exercise therapist, and nutritionist, and able to work with them not only at work site, in the home, take them to the grocery store, identify healthy foods, teach them how to cook, and also actually motivate the entire family. I'll share with you an interesting and touching story. A nurse that actually participated in the cohort. Young family, have about 7-year-old daughter. She went home after a long shift, very tired, knowing that she needs to walk at least half an hour a day. But she said, today is not the day. I'm going to go to bed instead and take a nap. Her 7-year-old daughter actually came. That team come to our house, said that we had to walk. Let's go walking. And she's the daughter, so actually the one who actually get them out. And again, we also provide the family with fresh fruit and vegetable basket every week, and with recipes. Again, there's really that blocking and tackling, get everybody going. Glad to see, what's the impact. I got just a text before I came up here of the result of one of our latest cohort. One individual, her name is Ashley, and she worked in the transporting department of a hospital. She came to us about 3 months ago, part of the program. Her hemoglobin A1C, which is the indication of how blood sugar control in diabetes, way out of chart. Usually expect less than 7, less than 6. She was 18, which is way out there. Her cholesterol is out of control, and take multiple medication. After 3 months of this program, I got the text today, her hemoglobin A1C went from 16 to 7. Her cholesterol went down to normal. She dropped 2 or 3 blood pressure medication, and those are the success factor that we're looking for. And then finally, it's really the investment in what we don't know, the research-based component. We do a lot of wellness prevention intervention, but we also search for what's working, what's not working, that drive more effective care. Some of you heard our medical director for wellness and prevention, Dr. Arthur Atkinson, join us. We also recruit one of his colleagues from Johns Hopkins by Karim Nasir. Nasir is actually focused on cardiac intervention. And we asked the question, cholesterol, blood pressure, is that enough? Or whether or not there's other things. We're now looking into other things like lipid size, calcium scoring in the coronaries, to really drive the appropriate intervention for the right patient, and hence reduce costs. And finally, the investment we made through the leadership of Brian Keeley and the board, every dollar we put in, we actually saved the organization nearly $7.50. That's a huge ROI return for us. And actually, that's make it huge important. And at the end of the day, it's not only our family at Baptist Health, it's really the community. We work with our family, but also need partner with community. There's an initiative in the west side of town, in Miami, called the Healthy West Kendo. We actually partner with the local government. We partner with the local business, Toyota, Lexus, others, Publix, and also work with the farmers that are actually able to tap into like program like Farm Share to bring food, healthy food, access to food, because we recognize that there's plenty of food desert out there that you can preach to the end of the day, healthy lifestyle, healthy eating, but the family cannot get access to healthy food at a reasonable cost, the message will be lost. So again, leadership is about community and accountability. It's about the community and collaboration, and really do the hard work to really partner with those that actually need our health care the most. So thank you very much for the conversation.
Thank you, Dr. Tran. We're going to open it up here to questions in a minute, but you probably saw me taking some copious notes, but I was trying to pick up some key words from each one of you to see if there were any commonalities that we might be able to unite around. So for someone sitting in the audience that might think, well, I don't know, I'm not a hospital company, and I'm not a car company, and I don't run hotels, I do X. Well, maybe there's some themes that might go on. So if you'll indulge me for a second, these are the themes that I heard from each one of you. Hopefully I was somewhat spot on. From Mr. Bacot, I heard the terms flexible, adaptable, responsive, accountable, incentives, outcome-based, on the clock, time, change, subtle, painful, drastically different. From Dr. Luceri, I heard best health care, advanced care, prevention, primary care, clinics, on-site, visionary, disease prevention, wellness, technology, time spent with patient, privacy, trust, company time, incentives, and engagement. And from Dr. Tran, I heard leadership drives execution, walk the walk, invest in infrastructure, health fairs for all, incentivize, metrics, the 80-20 rule, getting everyone going, research, ROI, community, and collaboration. Now, they may have been said different ways amongst the three of you, but there's a lot of recurring themes there that I think would be very useful to others that might want to adapt some of your best practices that you've gone forward.
Well said.
Very well said.
At this time, if there's some questions that maybe somebody might be thinking about, we'll certainly entertain those questions. Oh, there's one right here in the middle. Of course, I'm staring into the light, so can't really see for sure.
Hello, I'm Victoria Zepp, and I have just
Hey.
Hello. I have a question on your return on investment. For every dollar spent, 7 returned. What kind of formula, or how did you get to those numbers? How did you calculate that?
Well, thank you very much. The ROI, one of the preface on this is that Baptist Health very fortunate to have a very stable workforce for the past 10 years. And that's always often the challenge in terms of calculating the ROI, as if you have a high flux in terms of employment. Here is purely on the spent or cost avoidance. For example, if you look at diabetes prevalence, occurrence on a typical size employees and also healthcare related, you actually nationally run about, I would say about 10% diabetes occurrence. For Baptist Health, due to the intervention, we actually dropped it down to 4%. And that is a cost recovering and the investment we put in to yield that cost avoidance. For example, cholesterol and blood pressure or hypertension, for example, cholesterol over 240s, the national prevalence is about 50%, and Baptist Health employees percentage is about 34%. So that delta, again, focus on the investment we put in, infrastructure incentive, and programming that are able to prevent avoidance. The data actually come from two sources. One is related to our health plan cost usage, but also we also capture internal data as well through our employees' health clinic. Our employee health clinics actually, believe it or not, we invest in EMR, electronic medical records, for the employees' health clinic. And the question I often ask from my colleagues is why you invest there first rather than your clinical enterprise when you can bill. I said, this data that's streaming out of our employee health is so important to guide my decision on the benefits and also target the wellness programs, because these investments are not small investment, and it's so hard to judge and justify unless you have data. And it's really talk about really identifying the right thing to do at the right time and stop doing things that might not help at all. So thank you.
Very good. We have a question over here.
Hi, Sonia Dean with JM Family. I probably know the answer for our company on this, but for the other panelists, what is the most creative program that you've implemented for prevention-related healthcare? Creative or successful program?
Well, let me take a crack at that first. Again, creative. One of the things that really drive me as a chief medical officer crazy is when we go into our own cafeteria and you see food that's served very unhealthy. I actually cringe when I was in the food line today of the dessert that, quite decadent. You can enjoy, but maybe smaller portion perhaps. That's a suggestion for our friend here. But so for that, we actually incentivize, we put in a healthy meals and actually make it lower cost for employees that actually choose that healthy meals. And we also have a competition of the Iron Chef, but based on healthy recipes. And we did that all around our campuses and actually have employees submit the healthy recipe, and we actually feature them as celebration for that. So again, those are the fun things, engaging, and then we make that recipe, including in the healthy book that Brian actually published, for example. So those are the things that connect to purpose and actually drive the engagement, the fun, and the message that we do. And then finally, all the vending machines we take all the nasty drinks out, and we make it smaller too if there's available in the cafeteria, because we do have guests from outside as well. So again, but those are the tough decisions you have to make. Sometimes it's not popular, but it's the right thing to do.
Well, I have to say, Dr. Trent, I'm glad I wasn't standing next in line to you at lunchtime, because I'd probably come up here with a limp, I think. So, do either one of you have anything to add on the creative question?
Well, I don't think we have anything as too sexy as it relates to being creative, but just very commonsensically, we just lowered all barriers to care, okay? Anything to do with prevention, we just lowered the barriers. Our housekeepers make a certain level of income, and to have, for them to have to pay $10, $20, $30, $50 for a prescription or for a doctor's visit just doesn't make any sense. There's some great short-term savings associated with denying them care, but in 6 months, 9 months, 5 years, it comes back to bite you very hard. And so we just have really lowered the barriers to care and just reduced our co-pays and any sort of out-of-pocket almost to nothing. We have no deductibles on our health plan. Our out-of-pocket, I guess the Affordable Care Act forced us to put in the out-of-pocket at I think it's $6,250 for an individual and $12,700 for a family, and we were just kind of cracking up. Do we really need to put that in there? I mean, we could not get the entire family to spend more than, you know, $2,000. You know, how could we even get there? But anyway, long story. But we just lower the barriers to care.
Matt, if I may add one more thing, and again, it's not innovation, but it's, again, the infrastructure component. We really recognize on Baptist Health, beside the access, is about, I think the previous panel talked about, is the workforce issues, the shortage of nurses, and also physicians. We at Baptist Health recognize that, particularly primary care. We develop our own residency program to really prime for the resource of the future. The other things that I think, you know, we as a system advocate for the use of mid-level nurse practitioner to that allow them to practice to full capacity of their licensure. And we find that, again, we have 2 medical directors within our health system for employees' health clinics. And we utilize a nurse practitioner, and we really amplify the ability to take care of more of our employees. And when you look at the primary care need for our community in South Florida, it's really going to be the same thing, you know, whether or not we have enough adequate physician. So I think it's also a very, very important consideration as well. So thank you.
And Dr. Tran, to your point, you know, certainly the legislature is looking at many of those issues this year, not just related to nurse practitioners, physician's assistants, nurse anesthetists, across the spectrum. And you look at Florida, and while we are growing jobs, and while our economy is going great, and there's an awful lot of attributes, and you know, 1,500 miles of coastline will make people want to come to Florida, and on most days, sunshine.
Yep.
If you're a healthcare provider in that mid-level, however you want to call mid-level provider range, it's a big Herculean leap for you to want to leave your state or build your practice in Florida,
Right.
because it's a different ballgame in Florida.
Yes, indeed.
And so I'm excited this year that we're going to look at those issues. If it were up to me, I would treat our system just like the VA does, and that everyone should be able to practice at their full level of training. I think it's, hey, great, I got groupies. But I think there's a point in which you have to say, well, look, you know, 49 other states cannot be wrong and us right.
Right.
At some
Thank you.
point, we have to recognize that it's time to move forward, and to move forward because in our state, where you have some of these challenges of access, and I know it in my district, it's phenomenally important that we spread things out a little bit. Those employers in those areas are struggling.
Absolutely.
They're struggling with mandates. They're struggling with the terms that they're going to have to be dealing with. You know, we have 8 counties without hospitals, for Pete's sake. 8 counties in the state of Florida without a hospital. Right. And so how do those employers deal with their health care? And I can tell you they're not in huge counties, so some differences there. Are there any other questions out there? Sorry, I didn't mean to editorialize. Anyway.
Hi, I'm Joel Bays from Walgreens, and we actually have an on-site facility at our corporate headquarters up in very cold and snowy Deerfield, Illinois. My question is, in a large metro area like this, how do you get your employees to use it and use the facilities when they may live far away and may be more convenient to use a doctor's office that's closer to their home?
I think this one is to either of you. Yeah.
Thanks for the question. It's an excellent question. We have some experience with that since we have clinics in different parts of the eastern half of the country. The challenge is not so much for the people who work at the facility. Close to 85% of our on-site associates use our facilities almost exclusively for primary care. The challenge for us is getting their spouses in, and they may live in a perimeter that could be as much as an hour away. So we try to make it worth their while also. I'll give you an example. In one facility, we brought on a couple of gynecologists to help the wives of associates come in for their annual well woman exam. And since that is not a recurring need, you get it once a year, you usually don't have to return, they seem to be very happy to avail themselves of those kind of services, and then we can correspond with their local gynecologist if anything happens in between. We're trying to do the same thing with with the whole idea of spending an hour with a physician for physical, because we also provide any imaging services, lab work, et cetera, all free of charge if they actually come in and use our facility. So with that type of case also, somebody living far away, for the rest of the time that they get the flu or, you know, any other type of care that they need, we can correspond, or our nurses can team up with the local physician. So we don't want to deprive anybody of their own personal, you know, physician relationship, but we would like them to take advantage of some of the things we offer. So that is a challenge. We're looking at different ways of actually increasing that utilization. But the desire to engage is really the key. The average age of our population is 41. We're not talking about old people. We're not talking about, you know, lots of heart attacks or strokes. We're talking about people who have risk factors for those later on. So it doesn't really involve a lot of their physical presence. And I was so happy to have that discussion with you, Representative, offline before, about how you truly believe in the mobile health and the expansion and the scope of practice and all that. I think that's key. It's not an either or, it's all of the above. It's really all of the above. We'll do whatever we can to make the connection. We have 750 associates who live in every state of the United States, Hawaii included, and Puerto Rico. They work from home, and they're field representatives to outside dealers. And we would love to be able to connect with them, have them see us in headquarters for their annual physical, and then follow up with them electronically. So I think it's, we're excited to be part of this, this whole mobile health revolution, which is going to really help us.
Well, thank you very much. Audience, thank you very much for your questions. We're done and appreciate your attention.